Now, it was Valentine's Day yesterday, so I want to give you all a gift, a belated gift of our paper. So if you find me on Twitter, there's a pinned tweet and there's a link to this paper, which is freely available for the next, I think, 43 days or something like that. But anyway, so the reason I bring it up is to humble brag. No, it's to, it's really to kind of talk about what I was interested in when I first started exploring this more, was that actually a lot of the literature is theoretically based. And I wanted to know, well, what does it actually look like? You know, what is happening? What are people doing when they are being psychologically informed? It sounds very mystical and very fantastical. So what we did, so again, being at University College Hospital, we're very lucky because University College London is right beside us, and there's loads of interesting minds there and great brains, and they often come to us to ask questions about, we've got this question, or we're thinking about that. Do you think you could help us, or would you be involved? So Professor Nadia Bianchi-Bertuzzi works at the Center for Human-Computer Interaction. And they were really interested in developing or looking at whether it could be possible to develop AI and kind of supportive tech for people living with long-term conditions and in particular pain. And she and her team were coming in and filming some of our clinicians as part of a different study. But by doing so, they were collecting a lot of rich data. So this study, this paper came out of that because this was, if you like, the data that they weren't using that I thought was really valuable, because it speaks to what actually is happening when we're working with people in this way. So what they did, they filmed 4 of the physios delivering a class, a regular class like they work. So it would be an exercise group or part of a movement group at one of the pain programs. And the 4 physios had ranged between 9 years of experience up to 17 years of experience. They all had done some form of postgraduate training in pain, whether that's explain pain type course or something else. But 3 of them had done masters in pain. And what we did was we looked at what they were doing and then mapped it onto the CBT competency framework that's been developed by UCL's Center for Psychology, and that's freely available online if you wanted to look at that. But we identified broadly 4 themes that were coming out here. And the first of them was that the physios, when they were working with people, they're developing a therapeutic alliance. And I know Maxi spoke last year really brilliantly about this, so yeah, thank you. So you all know what I'm referring to here. But what I want to do with this paper, again, what's I think different about this is a lot of it is taken up with just giving examples of what actually the physios were saying. So they were filmed for an hour, and then the film, a psychology researcher met with them for an hour and played the film back to them and paused it every so often and said, what were you doing there? Or why did you do that? Or what was the purpose of that action? Or why did you say that there? So as you can imagine, that could potentially be quite intimidating, but it was actually a really excellent opportunity to do some reflective practice. And so I wanted to just read these out. So I often try to repeat the actual words that people have said, to acknowledge hearing them, and to kind of mirror, you know, I've heard what you have said, and reinforce that that's a helpful thing that they have said. So that's an example of kind of trying to build up the therapeutic alliance. The next theme was around reducing perceived threat, which might include, you know, normalizing their experience. You know, what you're feeling, those symptoms, those signs, they're normal. Lots of people who are living with pain will describe similar things. So participant D, these are the physios' quotes when they were asked what they were doing. So when they're moving and stretching and they hear clicking, it can be quite frightening. So it's just to remind them that these are normal sounds. We'll have talked about what they are, what the clicking is, and what's going on in the body previously. So we don't go into huge detail, but it's just to remind them that it's kind of normal. So that's trying to normalize their experience. Another one, there's a bit of a myth that exercise has to be done in a certain way or it's not right. And actually there's a spectrum and there's lots of ways you can do it. So it's finding what works for you. It's giving you options. And then the patient or person can choose what works best for them. So what I'm hoping is what you're starting to see is there's nothing particularly rocket science in this, but it's stuff that perhaps we're all doing already, but it's just nice to see it, to record it. The third theme was around reconceptualizing beliefs and somatic experience. So some of the examples of quotes here from Physio B. Sometimes I might get to the point where we're just getting stuck. So I might go more into, how about we set up an experiment? Or how about you give an alternative approach and give this a go and just see what happens? It might be that that way is better than your way, or it might be that you like the new way. So just trying things out, offering choices to people. If we tell a patient, next stretch, you're going to have to bend forward, for example, you might already trigger off some ideas in their brains that go, oh, bending forwards is really bad. But if you just start doing it and then talk through it as you're doing it, there's something that says to them, oh, actually, I'm bending. That recognizing the achievement. The final theme that we identified was fostering self-efficacy that Dr. Knoll has already mentioned. The ultimate aim is for them to move with confidence rather than moving in the way that we want them to move, what the Physio C said. And this was when they were giving instructions in the group stretch. In a group where you're doing stretches in context, gentle is fine. So using that term, move gently. But sometimes in letters, I think the word, you just have to be careful in case gentle means be careful not to. So sometimes that kind of delicate balance between some of the messages we're giving explicitly versus what implicitly people are taking from them.
Thank you very much. I really loved all the Muppets, actually. Okay, so questions. Let's see here. So this is from Jeff Bostick. Thank you for your talk. Given the full curricula and pre-licensure training programs, what are 2 or 3 key ideas you think pain educators should focus on to help students begin to develop knowledge, skills, attitudes in psychologically informed practice?
I'm just seeing the last word, Sláinte, yeah. Lovely. Yeah, good question. I think for, is it undergraduate or, so you might need to translate this for me in terms of the difference between, is this for qualified physical therapists or people who are
I'm not sure. It says pre-licensure training program, so perhaps before you're a licensed physio.
Yeah, so obviously the most important thing is to have those opportunities to do the clinical placements and to work with supervisors and mentors who have that experience. So that's in place, right? You're already doing that. If not, it's about identifying where are my local pain services, where are they? And if they're not local, or could you reach out and contact somebody online, an email, and identify somebody who perhaps may be willing to offer some mentorship or just to chat with you about it. It's coffee is always a good place to start. I think. Look, the Physiotherapy Pain Association are trying to lobby in the UK that we have more time at undergraduate for pain education, and I know there are some educators in the audience, and we know that there's a lot of pressure on the curriculum and what they have to include. So it is difficult, but it is something we're chipping away at slowly to raise awareness and to try and increase that aspect of undergraduate training. Yeah, and I think for me, it's all about identifying people who have experience, whether that's contacting psychologists in your region or physiotherapists who have worked in pain services for a while. Just reach out.
Awesome, yeah, ask for help, because I know that's certainly something that's challenging here in the States with our billing.
Right.
And how we try to teamwork and refer appropriately. But then, so we don't have another question, so I'll ask. So we have some psychologists here in the audience, and doing the psychologically informed PT, do you, in those classes, or do you have any suggestions as to when it starts to be not my scope? When is it I know some words, but also this is not what I can help with?
Thank you. You've been reading my slides, haven't you? That's a great question, and I should have mentioned this,
I
actually.
wasn't, but...
So we did in that paper, which you're free to download and read, we talk a bit about this, that there is a concern amongst physiotherapists around recognizing when is it outside our scope. And actually, often it becomes quite clear to people quite quickly, oh, that's outside my scope. What may be happening is actually people, because of a lack of confidence, clinicians might be saying, oh, I can't really deal with that, when in fact, if they had the psychologically informed skills, they may be able to deal with more of them than they realize. So we're often more cautious about saying, actually, oh no, I'm not saying that, but if someone starts crying, oh no, I need to refer them to my colleagues, the psychologists, because they're really upset, when actually we may be able to deal with that. So we kind of comment on that in the paper, how physios are quite good at identifying, almost to the point of reflecting a lack of confidence in being able to manage.
Since there's still not another question, I'll actually keep this conversation going. Is what's interesting, so I actually work in an interprofessional clinic, primarily student-led. It was interesting when the psychologists were kind of like, look, so they do anxiety and depression screening coming in. They're like, we'd kind of like to stop screening the PT patients because we keep getting false positives. And I was like, what's a false positive on an anxiety and depression questionnaire? And it was actually, they felt that it was really tied to their physical symptoms, like what they were presenting for. So I think I'm really excited for your paper, which is on the Twitter feed and on the app. Thank you, Sandy. So that you can check that out, because I think it goes both ways. I think sometimes we're like, oh gosh, I don't know that this is my business. But then also I think on the flip side, people become anxious and perhaps depressed because of things that are being perceived as just physical.
Right.
Do you know what I mean? So it's that interdisciplinary, interprofessional. I'm really excited to see that coming out more with you.
Yeah.
So, yeah. Okay, more questions. Time is an issue for implementation in the U.S. Any thoughts on the time this takes to actually do in practice, and how do we get paid for it? By Sandy Hilton.
Thanks, Sandy. I don't think it needs to take a long time to, approach somebody in a psychologically informed way. And there's a really nice example of in the BMJ Open on brief interventions, for example, to deal with distress in a GP appointment in the UK, where they have about 7 minutes, and there are things that you can do and you can apply. So it doesn't need to take a lot of time. It's more a way of working with people than an actual treatment. How do we get paid for it? That's a good question.
It's an unfair question.
Well, it's I'm not sure I understand fully, because I guess you're still delivering physiotherapy or whatever treatment you're delivering. You're just delivering it in a psychologically informed way. So your treatment, however you charge, that shouldn't affect that in any way at all.
That was a beautiful answer for what she was trying to stir the pot a little bit.
All right.
Which I really love. And here's a great question from Jim Stark, which is, are your Zoom classes / training still available and open?
Oh, yeah, thank you. The plan, and actually I'm quite excited about this, speaking to some people, is to look to the PPA, the Physiotherapy Pain Association, would like to develop a group of experienced mentors / supervisors who will be willing to, once a month, join an online Zoom. And people can come, and using that model, the group reflecting model, it's a really nice way for people to bring cases, and then the group collectively vote for the one they would like to focus on. So the short answer is, currently, because we've literally just finished the pilot and we're starting this monthly, but the plan will be to roll that out. So keep an eye out. Keep an eye on the Physiotherapy Pain Association webpage. Consider being an associate member, and then we'll keep you up to date anyway, yeah.
That link was also tweeted out and is on the list on the app. So you can check it out if you're like, I just need to click. It's there for you. Okay, now we have a question from Uchenna Osai, right over here. How do you address implicit bias in the training of students and clinicians of psychologically informed physiotherapy?
Well, that's a great question. So I mentioned part of the pilot that we ran was a survey, and some of those were like the PANAS, which is looking at them bringing awareness to what they're bringing to the table, I guess. And as part of the training, we were, so for example, in the second half of the online training, this idea of getting stuck, we would do functional analysis with people to really analyze that, to think about what's going on, what's been happening in their lives and their situation before, what are they thinking, trying to bring awareness to any biases that may be present and may influence their experience of working with somebody in that moment. So it feels like it very much is part of the approach is to bring awareness to what you're bringing to the table, if that's answering your question. Yeah, but great question.
And then we're going to move down the line over there to Jamie Lowy, who's asking, how often does your team reassess the psychological screens for issues like anxiety and depression to determine if treatment strategies need to change?
So where I work, we use the HAD, the Hospital Anxiety and Depression Scale, but we tend to use it as an outcome measure pre-post. We don't really use it as screening because I guess, again, I'm in that fortunate position in my bubble of working in a team with psychologists and psychologically informed clinicians that we would be assessing that while we're working with somebody. But how often should you reassess in kind of an outpatient setting? I think certainly you're going to screen at the beginning, but if you're not helping somebody to move forward, maybe that should be starting to flag up. Actually, is there more going on here? Do I need to check that again? It's not going to be a black and white when you should do it. It's going to be more about how you're getting on, I think.
Excellent. So I think the only final question we have is from Dr. Neil O'Connell. And it is, are you willing to give us a rendition of It Ain't Easy Being Green?
No. If you had asked for the rainbow song, I might have said yes, but no.
Okay, so then we will close the session. Rajam asked, actually, so she wanted to see about people getting up and moving around. So we wanted to challenge you a little bit, and we'll do a different challenge over lunch. But at the World Congress of Abdominal and Pelvic Pain, Sandy Hilton came up with the idea of like just a movement nibble, a little movement minute. So we're actually going to pull up a little bit of music before you go. And then I already asked him, Neil said he would kill everyone in the room if I did this to him, but I got permission. So everyone just stand up for a second, because we know that movement is, pretty darn good for a lot of things. All right, so just for a minute. Okay, so I actually kind of like all the movement. You can get your arms up. And then most of you who know me know I'm also a pelvic therapist, and we don't move them enough. So here's what we're going to do. I'm going to get you later. So just start a little. You don't even have to move your feet, so you don't have to say I'm tripping. Okay. And then legs straight, and just shift us side to side. Oh, you can do the arms too? Absolutely. And then we're going to go around in a circle. So you're just going to go around. So the top kind of stays still. Good. Just like you said you would. And then reverse it. And then we're just going to do one more thing. So it's going to be the same on the bottom, but you're going to imagine you have a beautiful scarf. Good. And then the other way. Ready? All right, beautiful. Go have your coffee, and we're going to start back at 11:30.